Matthew. A question that is going to, I think, lead us quite nicely into our next presentation from Aidan Doherty. Do you have any plans to include compositional data analysis, which really lends itself to activity type?
That's a very lovely question, and you're right, that does go very nicely into Joe's presentation. So Joe will be covering activity intensity, but this question, yes, there are plans in the immediate future with ProPASS data resource to address compositional data analysis with activity type.
Thank you, Matthew. Great presentation. Let's move on to our fourth and final speaker in this first session. So this is the piece of work that Manos prefaced in his introduction. Our presenter is Dr. Joe Blodgett, Senior Research Fellow at the Institute of Sport, Exercise and Health at University College London. And you can see the title for Joe's presentation on screen now. So I will hand over to Joe.
Great. Thank you, Andy. So I wanted to start off with an announcement that Manos has already alluded to in his opening talk. So we're really happy to share that our first database paper, so using the ProPASS pooling resource, has been accepted for publication in the European Heart Journal. So my presentation today is going to be a sneak peek of some of the results and then a brief summary of what you can expect weeks. So just to add to Matthew's presentation about where this work sits, as part of the British Heart Foundation grant, we have a large project aimed to better understand how the full spectrum of physical behaviors are associated with cardiovascular disease risk and all-cause mortality. The specific aim of this paper is to look at associations between compositions of the 24-hour movement behaviors and different adiposity and cardiometabolic biomarkers as outcomes. So as we know, cardiovascular disease is the world's #1 killer. So it's responsible for about a third of global deaths, and this is quite disproportionate compared to the other causes. One of the major risk factors is physical inactivity. And the reason why we're all here today is to look at a factor that might be able to prevent or mitigate different disease risks. So this is physical activity. So this infographic here highlights some of the main globally accepted recommendations on physical activity. So this is about half an hour a day of moderate to moderate intensity activity, or 2.5 hours per week of moderate to vigorous intensity. However, this is still quite a one-size-fits-all approach, not getting into more detail on activity type, on intensity. And a lot of these guidelines have sort of resulted in a public health message about moving more and sitting less. This is a fantastic message for many, but for us, we really want to get into what this means. How can we dig into what type of movement should happen? What type of sedentary behavior should happen less? How often should that be? So the key gaps that we wanted to address with this piece of research was capturing all device-measured behavior across the day. So those previous guidelines are based largely upon self-reported data. So things like incidental activity, maybe running for the bus, or even how long you're standing or doing dishes might not always be captured in self-reported data. As we saw in Matthew's presentations, there's different associations between different activity types and different postures. So it goes beyond just capturing physical activity as a whole. These movement behaviors are related. So we know that they occur within a 24-hour finite day, and any increase in one behavior is going to have an impact on the others. So we wanted to look at this independence, and we also wanted to estimate how changes in one behavior could impact different outcomes. So for example, if we decrease 20 minutes of sitting and replace it with 20 minutes of moderate to vigorous physical activity, how could that theoretically change something like BMI? So a brief description of the pooling project cohort that Matthew gave a nice introduction to. We have just over 15,000 people across the 6 cohorts. It's a middle-age cohort, so an average age of 53.7. About half are female, and it's still a fairly healthy sample, although about a third are on medications, and about 10% have a previous history of cardiovascular disease. We focused our 24-hour behaviors on a 5-part composition, and I really want to highlight standing here as something that deviates from the way a lot of 24-hour compositions are presented. So we often see 4 parts, but here, using the ActiPass method that Peter presented, we were able to differentiate standing from more sedentary or more light activities. These are the list of covariates that we adjusted for, and we also further adjusted for an additional set that weren't captured in all 6 cohorts. And then we looked at 6 different outcomes. So for today, I'll be focusing again on BMI, but the whole paper itself goes into detail on each of the 6 outcomes. So we used compositional data analysis, and this allowed us to examine how time reallocation between behaviors would have a theoretical impact on the outcomes. I mentioned earlier some of the benefits of this, but specifically that this method recognizes the finite nature of the 24-hour day. So more traditional regressions might say for every 1 hour increase in sedentary time, this is the impact on your outcome, not recognizing that there is a cut point within that, a natural cut point within that 24-hour day. And then also it recognizes that these behaviors are highly related to each other. So challenging to look at any of them in isolation. So on to the results. So this is the average composition of the sample. So this is what we use as a starting point. So we see that the sample had nearly 8 hours of sleep on average, was sedentary for about 10.5 hours a day, had quite high levels of standing, which is really important. As I mentioned, we want to be able to differentiate that from other activity or sedentary behavior types. They spent about 1.5 hours in light intensity activity, and then our moderate to vigorous intensity activity, driven largely by high brisk walking, was about 80 minutes per day. And this is an overall summary of what we found. So generally, we found that more time spent sedentary relative to the other behaviors had a negative impact on all of the outcomes, whereas more time spent in any of the other 4 activities, so sleeping, standing, light or moderate to vigorous physical activity, had a positive association. And to dig into a bit more is that we found a real hierarchy of behavior. So it wasn't as simple as behaviors being good or bad for any outcome, but rather it depended on what the behavior replaced. And sleep is a great example here because it is beneficial if it's replacing time spent sedentary. But if we are increasing our sleep at the expense of activity, whether that's MVPA, light activity, or standing, that's when we started to see more negative effects. And I've put these 3 behaviors in the middle, light intensity, standing, and sleeping, just to highlight how close the relationships were. So there's still a hierarchy, but it's a bit more complex and a bit more nuanced than the clear benefits of moderate to vigorous physical activity and the clear negative impact of sedentary behavior. So using BMI as an example, we looked at the reallocation plots. So what we did is we took the reference composition, so the average person in the sample. These figures are adjusted for age, sex, and cohort. And we looked at what their typical day looked like. So we see someone with 10.5 hours of sedentary behavior. We wanted to see what would happen if we replaced other behaviors with sedentary time, adding in more sedentary time. And we saw this hierarchy of behavior. So if we're replacing our moderate to vigorous physical activity, which is at the top of our hierarchy, with more time spent sedentary, so here we see about 30 to 60 minutes, we can see quite a stark increase in BMI. And you can see that the sort of slope of the line decreases in this hierarchical way. So replacing standing and sleeping at the bottom had a less deleterious impact than if we were replacing physical activity. And we can look at both sides of the graph. What happened if, probably something we want to do more, we replaced our sedentary behavior with these behaviors. And again, you see that hierarchy here. More time in moderate to vigorous physical activity was associated with this theoretical reduction in BMI. This plot here is very similar. So instead of for sedentary time, we're now looking at moderate to vigorous physical time. I note that the axis is different. So now we're looking at minutes instead of hours, which is why the slope of the lines are slightly different. But we still see this hierarchy of behavior, a bit more overlap, given we're looking really at sort of 30 to 50 minutes of behavior being replaced. And then we also wanted to quantify what happens when we increase, so we add in some of this beneficial activity, the moderate to vigorous physical activity. And we again see this sort of graded impact on our outcomes. So sedentary behavior, which was the most deleterious behavior, could theoretically, so replacing 30 minutes of sedentary behavior with 30 minutes of moderate to rigorous could theoretically lower BMI by 0.63. So what you can expect from the full paper is these reallocation plots for every behavior. So thinking of a 5-panel figure, one for each of the 5 parts of the composition, describing the reallocation between every pair of behavior. We did this across 6 detailed outcomes. So BMI had sort of the clearest outcomes, very, very clear to see the difference between those 5 behaviors, where some of the other cardiometabolic biomarkers had some more nuanced associations. We also stratified results by males and females, and sneak peek is that we observed a slightly stronger association between the behaviors and the outcomes in females, and also slightly stronger associations in those with lower levels of MVPA. And this makes sense. If someone has 100 minutes of MVPA per day already and they're adding 30 minutes, it's not going to have as much of a benefit as if you're starting with 5 minutes and adding in that extra half hour. And then also we looked at defying some of these theoretical changes. So I gave one example with 30 minutes, but we look at this across all outcomes. And we also quantified the minimum behavior change needed to observe a difference in the outcome. And this was as few as 5 minutes per day for some behaviors and outcomes. And then also looking at what behavior change would be necessary to observe a clinically meaningful change in BMI. And we used a decrease of 5% as our reference there. So just to summarize the findings, we found that MVPA was the most beneficial behavior and that sedentary behavior was the most deleterious. This was consistent across all outcomes. And then we observed the general hierarchy of behavior that were most beneficial for the 6 outcomes, with a little bit of overlap between light activity, standing, and sleep. So some key implications. These results here specifically with MVPA really highlight that the intensity of the activity is essential when we're looking at these cardiometabolic outcomes. So we do have to move beyond the simply sit less and move more. Perhaps light activity that isn't causing any demand on the cardiovascular system might be fantastic for musculoskeletal, for mental health, but isn't having a large enough impact on the cardiometabolic outcomes. However, we did note that the benefits of physical activity overall is greatest in those with lowest levels of activity. And then kind of coming back to my first point about this intensity activity is that there are different ways to modify the movement behaviors to get benefits. So while MVPA certainly seems to be the best in terms of sort of the time efficiency, so for a short period of time, you can have the largest theoretical impact, it is still possible to modify it in ways that are more feasible. So maybe MVPA isn't possible due to prior health conditions, for example. So there is some individual feasibility that would have to be considered. But again, if there was no constraints, I would say from a time efficient perspective, MVPA is really the best sort of bang for your buck in terms of improving your health. And just to acknowledge sort of everyone who was involved in these projects, as we've alluded to, it has been years of work, and it wouldn't be possible without all of these people, without our funders, and of course, without the help from the cohort PIs and the participants themselves. Thank you very much.
Thank you, Joe. Excellent presentation and a great job in distilling what is a very dense and complicated set of results. And just to echo what you've also said, they are a huge amount of work over a long period of time, and great to see that out there and being published in really great journals. We do have some time for questions. If you haven't posted in the chat yet, please do so. We have a few minutes. First question I'd like to come to here is in reference to your hierarchy of activities. And in those analyses, in those models, are you assuming a linear association between sleep and health indicators? I guess that would also apply to other activity types as well. So are we assuming linearity in those models?
Thank you. That's a great question. So the model itself is not assuming linearity. We could have observed a nonlinear association with sleep there. We didn't, but sleep is a very complex behavior, as we know. So we were sort of not necessarily with this data set, with this small data set so far, but we're expecting to see that low levels of sleep and high levels of sleep might be adversely affected. So this is something that we really want to look into. As Peter discussed, we do have some limitations in sleep in that we're truly capturing time in bed right now. So this isn't capturing the quality of sleep. We do have some self-reported measures that we are trying to harmonize to better understand how quality of sleep might impact the outcomes themselves. So still very much an area that we're trying to explore.
Thank you, Joe. Given that we have a little bit of time, I thought we could revisit one of the questions that actually came in for Matthew's presentation, but I think it's relevant here as well, in that our analyses up to now are using intermediate kind of metabolic markers as outcomes. We have a question from Tim Chico. What level of healthcare data is activity data linked with? Do we have it linked with electronic health records, for example? So just looking perhaps a little bit further down the line for us in ProPASS.
Thank you, Andy. I can answer this one. So the short answer is that it really depends on different cohorts and what they've actually collected. So some of our cohorts have only recently collected accelerometer data. So in the last couple of years, we don't really have enough lag time yet to be including prospective measures of health. I can speak about BCS 70, which is a UK-based cohort, and it has fantastic linkage to hospital episode statistics. So we are able to derive measures based off of ICD-10 codes and mortality. Again, this is something that's going to vary for most cohorts, but we're trying, that's in our sort of plans over the next year, is really to pull in those longitudinal outcomes, harmonize those in order to obviously improve the type of evidence that we're presenting here.
Thanks, Joe. We'll go with one last question before we draw this first session of the conference to a close from Andreas. Will the advice based on the results be the same for participants with various compositions, i.e. those deviating from the average? For example, participants standing for many hours with few hours of sedentary behavior and some physical activity.
Thanks, Andreas. So we were able to hint at this when we stratified by low and high levels of MBPA. We just used a median cut point to separate those. I think the short answer is that we're not expecting them to be the same. And it's nice to think about this anecdotally. So if we have somebody who has a desk-based position, so they're sitting all day, perhaps sitting on their commute to work, sitting watching TV at night, the benefits of replacing that sitting time with MVPA is going to be a lot stronger than someone who might have a more manual-based job. So on their feet all day, perhaps heavy lifting, so some high-intensity activity involved there. And actually, perhaps the sedentary behavior of someone who is active throughout the whole day might be a benefit. So maybe the recommendation needs to be having a bit more rest at night. So one thing that we're very keen to develop is more personalized guidelines. So if we think about the reference composition, that was just an average for the whole sample. But if people are able to give their current day, so what does a 24-hour day look like to you? What are your activity types? So using the variables that Matthew presented, then we can look at and model how different reallocations might have different impact on the outcomes.
Thank you, Joe. And thank you to the other three speakers in this first session. We'll draw this first half of the day to a close. We're going to take a 15-minute break now.